Okay, I'm going to start here with a few cases, and we're going to shore up some of those gaps that you guys were questioning what we would cover. So, again, no disclosures. So here is case 1, 27-year-old man. He's undergoing evaluation in neurology for a TIA. They noted on his intake that he had hypertension. Thanks. So, young man, hypertension. You guys should be primed to make this diagnosis now from the stem of the question. And I'm showing you the arch. So here's the arch. There's the blood pressure up there, 162/74. Oh, there's the color in the arch. It's kind of laminar. There's the Doppler profile. Peak velocity, if you can't see it easily, 1.3 meters per second. No diastolic forward flow. Does he have a coarc? Because that's what we were thinking I was priming you for. Yes, no, or not sure? Okay, I like your test taking. 49% of you not sure from what I've shown you. Well, here we go. The answer is actually yes, but let me show you what the trick was here. So this is this patient's axial imaging of 3D reconstruction of his aorta, and you see here that he has complete interruption of the aorta with flow to the distal aorta constituted by collateral formation. So we saw laminar flow because we were actually just seeing flow going out to the left subclavian. We weren't seeing a true obstruction and high velocity flow down the descending aorta. So how can you not miss this in echo? Well, here's the key, and this is the abdominal Doppler. So this should be our number one diagnostic tool for anyone with coarctation, whether it's tricky like this one that I was showing you or not, because coarctation of the aorta that has significant obstruction will give you an abnormal abdominal Doppler flow. So you'll see this slow upstroke and then continuous forward flow in the abdominal aorta. So actually, instead of thinking that your arch is the number one picture, I want you to think about abdominal Doppler flow for coarctation. So again, this would be significant coarc if they show this to you, or you see it in the clinic. This is normal Doppler flow. So you see this normal abdominal Doppler flow, unlikely to have any significant coarctation. So here is maybe a little bit more common picture that you would see. I mean, that was tricky, the one with complete interruption. So here we see the arch. You can see some flow here. It's continuous blue flow. And then here is the Doppler pattern down the descending aorta. So high velocity because there's some obstruction, and continuous forward flow post-obstruction. So this would be very classic coarctation of the aorta, what you might see at the notch. But I just wanted to show you that first case to emphasize the point. Don't believe that just the arch is your only view. You may not see this classic pattern, but in either case, your abdominal aortic Doppler will be abnormal. Okay. So remember with a coarctation that gradient, that Doppler gradient that you get in the thoracic aorta may also not reflect the severity of the obstruction, because there could be a ton of collateral formation that's sort of reconstituting flow to the descending aorta, so the pressure gradient may be low, but you have significant obstruction. Think about that continuous forward flow, and then if you see a patient in clinic or on the exam that they're showing you a coarctation, don't forget the association with bicuspid aortic valve and be looking for that. So if you have a coarctation, about a 50% chance, maybe slightly lower, that you'll have a bicuspid valve. It's not true the other way. If you have a bicuspid aortic valve, less than a 5% chance you would have coarctation. Remember, too, that if they're showing you a postoperative patient, you can get not only re-narrowing at the site of coarctation, but aneurysm formation, especially in patients who had what we call left subclavian flap type repair. And those aneurysms can be difficult to see on echo. Here's a case of a young man. This was quite interesting. He actually was adopted after he had sort of his initial repair, and he was told that he had a VSD repair. He did have a left thoracotomy incision, and that was from what we were told was a PA band. So he was palliated initially, which would have been common in this era, restricting blood flow to the pulmonary artery with a band through the left thoracotomy, and then later going back when the child is older and closing the VSD. But then we noticed that his abdominal Doppler, you can see just from color flow, looks a little weird here. And then when we got up to his arch does not look normal. This looks funny and expanded here. And the color flow is quite unusual. Clearly a big expansion in the aorta. And this was his axial imaging. And so you see this large aneurysm formation. So at the time of his thoracotomy, he did have a PA band for his VSD, but they also repaired a coarctation that he was unaware of. So this was just a really beautiful case to show that, remind you that you can get aneurysm formation, and you could potentially see something like that question on exam. Okay, case 2. This is a 31-year-old man. He was told as a child that he had a hole in his heart, but his parents were told not to worry, you're not going to need any intervention. And then he wanted to get life insurance, so he had to have an EKG as part of this life insurance exam, and the EKG was abnormal, and he was then referred to the echo lab by his primary care physician. So here's the EKG. I don't know how well that's transmitting up there, but I want you to take a look at that. Think about what that represents. Here's his chest X-ray. And here are the echo images. So parasternal long axis view. Parasternal short. Apical 4 congenital format. Back to some parasternals for you. What's the diagnosis? Non-compaction, LTGA, DTGA, or Epstein anomaly. All right, so most of you thought LTGA, and I'm going to give partial credit for those of you who had said Epstein anomaly, because this was an Epstein-like valve in LTGA. The trap I didn't want you to fall into is non-compaction cardiomyopathy. And so that you guys did great on that. So let's review some of the features here. So congenitally corrected transposition, we heard a great example of how to tell L and DTGA in the last lecture, but here is just a specimen to remind us of the features of congenitally corrected transposition. So in this situation, the morphologic right ventricle is in the left-hand position. I want to draw your attention to a couple of things. So what we're really talking about with L, or congenitally corrected transposition, is that we have discordant connection here between the atria and the ventricle. So this is a morphologic right atrium, morphologic left ventricle, morphologic left atrium, morphologic right ventricle. So they're discordant connections. And then we have discordance to the outflow. So this morphologic right ventricle is connected to a pulmonary artery. And so what I want you to recognize on an exam is just get your left-right orientation correctly. And so remember that the tricuspid valve always guards the inlet of a morphologic right ventricle. That valve is formed embryologically as part of the right ventricle. So if you know which valve is the tricuspid valve and which valve is the mitral valve, you know which ventricle is which, and then you can go on from there to make your diagnosis. So look at the crux of the heart and see which valve is offset towards the apex. That's the tricuspid valve. And so that's going to help you out. Now, often in LTGA, the valve will be offset significantly towards the apex, or it will be Epstein-like valve. So let's look here again, just a different representation. And this actually is lifted from our artist. For those of you who are really paying attention, this is actually a little bit wrong because the aorta should be more anterior. So, but to give you the point that we have sort of corrected the circulation, but we're using the wrong morphologic ventricles to do that. So we have blue blood coming from the systemic veins back to our right atrium as we expect, but that blue blood goes to a left ventricle and is pumped to the pulmonary artery. So that's okay. I mean, the patient gets their blue blood to their lung, but on the systemic side, they're getting their red blood to a RV to the aorta. And so this RV really isn't equipped to handle systemic circulation, and we can have complications from that. But initially, these patients, as long as they don't have an associated VSD or other anomaly, might not be picked up, and they look just fine. They're not going to be blue or have other concerns. So I put this in your syllabus to remind you, when you're faced with what's the difference between DTGA and LTGA, I just wanted you to kind of block diagram to help you remember. So DTGA, we have concordant connections between the atria and the ventricle. So it's a right atrium connected to a right ventricle, but we have discordant connections from the ventricular to the great artery. So RV to AO and LV to PA. And you can see this is not compatible with life. This is a bad problem. We got blue blood coming back from the body and being sent right back to the body. So this is not a circulation that is going to be well tolerated. And as we heard, the mortality is about 90% at 1 year if you don't do anything. So if you're panicked, though, in test mode and you can't remember this because suddenly you're faced with it, remember that with DTGA, you die without a surgeon's intervention, and LTGA, you live. So D, die, L, live. So just keep that in mind. All right. So here's the things to look for on echo. This is for LTGA. So usually, if this was normally related, we had normal anatomy, we should have fibrous continuity from the anterior mitral valve to the aorta. In transposition, we don't have that. So we're thinking in this parasternal long axis view, this should be mitral and aorta, but look, there is muscle here. So there is not fibrous continuity. That's your first hint. And if you're scanning and you see this, the next picture you should get is your apical 4 to try to orient yourself to the ventricles. So we go to apical 4, and we see here that the valve that's displaced apically, and actually displaced quite a lot, is here in the left-hand position. So this is a morphologic right ventricle in the left-hand position. So now you've kind of made your diagnosis. You should have it in mind that this is going to be LTGA. The other things you can look for, say you can't tell if it's offset or there's something else funny going on, look for your secondary features of which ventricle is which. So there is a moderator band in the RV. So the LV is usually much smoother walled, less trabeculation, no moderator band. The other thing then you can look at is sort of look at how the AV valve attaches to the underlying myocardium. So a mitral valve has usually 2 dominant papillary muscles with no attachments to the ventricular septum, but the tricuspid valve, multiple little papillary muscles, and you can see easily chordal attachments to the ventricular septum. So those are some secondary features that you could use. And then parasternal short axis imaging at the base, once again, just like in the detransposition example that we saw, in the last lecture, we see both AV valves on FOS. They're not orthogonally related, they're parallel now. And so this is quite unusual. And then you can see that the aorta is anterior. There's a coronary artery coming off this anterior semilunar valve. This is anterior and leftward instead of anterior and rightward, as we saw in the DTGA case. So all of these features should trigger you for to think about L transposition. So things that you might see associated, very commonly these patients do have a ventricular septal defect, and if they do, they're often picked up in childhood. They can have subpulmonary outflow tract obstruction. They often have something wrong with this morphologic tricuspid valve. It either is a little bit dysplastic or, like in our case example, an Epstein-like valve, very apically displaced. So this is quite common, and this is an important long-term aspect of this patient or these patients' longevity, because if they develop significant tricuspid valve regurgitation, they'll get accelerated ventricular failure. So it's very important that we recognize this and treat tricuspid valve regurgitation. They can have situs inversus and dextrocardia. Just to keep that in mind, if you see a patient with situs inversus, dextrocardia, make sure you know how the great arteries are related. Let's just review Epstein anomaly real quick. So this is pretty rare form of congenital heart disease, comprising only about 0.5% of all comers. It's a complex developmental anomaly when the valve does not delaminate appropriately from the underlying myocardium. So this is not just a valvular heart disease, this is a myopathy. So the RV myocardium is quite affected. And so here is your echo features that you might be tested on, and the things you want to look for is intense apical displacement of the septal leaflet of the tricuspid valve, not just the normal offset, but more than 8 millimeters per meter squared of body surface area is a definition. So you're going to see right-sided chamber enlargement, significant tricuspid valve regurgitation, but remember that the actual origin of the tricuspid regurgitation is not going to be in a normal annular plane that you're expecting, because this valve is not just offset towards the apex, it's rotated often into the outflow tract if you think about this three-dimensionally. So you're going to have a very unusual plane of tricuspid regurgitation. It's most often severe. There are cases where you don't have severe TR, but you should assume it is until you prove otherwise. And then you can see this elongated, tethered anterior leaflet. So here's very classic. You might see this on an exam, apical four-chamber view, apex down. This is the right atrium. You can see that this septal leaflet of the tricuspid valve significantly offset from the mitral valve. There is this elongated, multi-tethered anterior leaflet. And this is a very unusual coaptation plane. We're really not seeing the true orifice of the tricuspid valve here, but this would be classic Epstein anomaly. Associations are going to be an ASD in 50%, and then accessory bypass tracts electrically that can cause arrhythmia. Okay, let's go do another case here. So this is a 38-year-old woman. She presents for an opinion on treating her pulmonary hypertension. She's very limited, and she's very cyanosed. So she has a kind of a complicated history. She was taken to hospital at 3 months of age for what was thought to be a pneumonia. And she, like our young guy who we didn't know had a coarc repair, she was diagnosed with a VSD, a patent ductus arteriosus, and a coarc. And she underwent a left thoracotomy during that hospitalization, had a PA band put on to protect her pulmonary circulation, had her PDA ligated, and her coarctation repaired. But unfortunately, by 6 years of age, she was diagnosed with Eisenmenger syndrome, irreversible pulmonary vascular disease from her VSD. She was treated unusually, and I wanted to hit these high points in case you're tested on them, but also so that you do the right thing clinically. She was treated with frequent phlebotomy. Now, patients who are cyanosed from a cardiac shunt lesion have an increase in their red cell mass, an increase in their hematocrit. This is not like patients who have a hematologic abnormality. This is how these patients deliver the appropriate oxygen content to their periphery. So phlebotomy is a bad idea for them. So you're depriving them of appropriate oxygen delivery, and you're also making it more at risk that they're going to have a stroke, because as you phlebotomize these patients, the red cells get smaller as they get iron deficient, and small red cells do not traverse the capillary bed well, and so these patients we've shown are more at risk of having a stroke when they're phlebotomized and microcytic than when you let them have their normal high hemoglobin. So there is no level of hemoglobin or hematocrit clinically that I phlebotomize a patient for. I phlebotomize only for symptoms of hyperviscosity, which is quite rare. She was placed on Coumadin in adulthood because she had pulmonary hypertension. Now, in primary pulmonary hypertension, it is probably a good idea to be on warfarin, but in Eisenmenger syndrome, these patients die from massive hemoptysis often. So you want to be very careful before you put an Eisenmenger patient on Coumadin. You need to have a really good reason for it. Then she was placed on a heart-lung transplant list for about 5 years ago. Now, she's pretty young and she is limited, so I'm not saying that it's wrong to think about transplanting these patients, but in general, with good management, we can get patients with true Eisenmenger syndrome to live into their 5th and 6th decade, which is much longer usually than we can survive a heart-lung transplant. And she doesn't recall ever being told that it was bad to be pregnant with Eisenmenger syndrome, so she was using no birth control. And we all know that that's probably not a good thing. These patients are at high risk. So she had some interesting clinical things, so keep that in mind on exam, things you might run into. She had very significant cyanosis. She was about the color of this background slide. She had conjunctival injection, which is a sign of her high hemoglobin. She had a 2+ RVM pulse. She had a 3/6 systolic murmur, no diastolic murmur. There's her clubbing, pretty significant. Here's her echo. Parasternal long axis view, little territory missing right there. Just a little better vision of that. You can see her right heart is now dilated here as she's aged, is very hypertrophied for you all. Parasternal short axis imaging, bicuspid valve. Remember, she had a coarc, so we don't want to forget that association. Looks pretty good. No turbulent outflow, trivial little regurg. Parasternal short, we're kind of scanning down to the mitral valve level. There's the color flow. Still frame for you. Pulmonary outflow. Pulse wave Doppler. Continuous wave. PDOF. Does she have Eisenmenger syndrome? Now we're split. So the 55% of you that said no, that you are correct. This patient does not have Eisenmenger syndrome. She definitely has RV hypertension, but let's look at a couple features. This was her pulmonary outflow, 4.5 meter per second. So she had obstruction to pulmonary outflow. The pulse wave Doppler was okay, continuous wave high velocity through her pulmonary outflow. So she has RV hypertension with a big outflow obstruction. So what do you want to do next? Well, you don't have to vote for this one. Let's just go ahead here. We don't want to. So I wanted to cath her. And so here we go with the cath. So injection into the RV, tight PA band in place with this little water pick jet coming through the band. I'll show that again here. So this lady had a tight PA band in an appropriate location. Remember, she got banded at 3 months of age to protect her pulmonary bed, and they did a great job because the band was super tight and it was doing its thing. Distal PA pressures were pretty normal, 35/11. Band gradient was 80 millimeters of mercury, and her pulmonary blood flow is quite limited, as you can imagine, less than a liter per minute per meter squared. So she's, no wonder she can't do what she wants to do, and she's so blue. Her coarc was well repaired. She had no residual PDA. So this is a lady with a big VSD and a pulmonary band in place. So the problem is The family was not a good social situation for her when she was 3 months of age, and she was placed in foster care. And like our other patient, things get lost in translation. And so when she was taken in for her pediatric checkup, it was the new parents were unaware that she had a PA band put on, and so people saw that she had a big VSD with bidirectional shunt and RV hypertension. They said, "Oh well, you've got Eisenmenger syndrome. There's nothing to do." So she actually was still reparable. So there's our cath picture, nice PA pressures, systemic, of course, RV pressures. So she had a PA debanding. Now she's almost 40 years old, and this is our oldest PA debanding at Mayo, and we closed her VSD. And her lungs really were quite interesting. She had such low pulmonary blood flow, and when we gave her normal cardiac output there, she had a transient reperfusion injury and got very wet. But she recovered well in hospital, and at 6-month follow-up, room air sat 95%. It was 68 when I first saw her, and she had a normal 6-minute walk. RVSP was not normal. I mean, that PA pressure was low, but that was in the setting of really restricted flow. So she did have some pulmonary vascular disease, and she actually was able to go and start a job. She was very happy to be able to be more active. So the teaching points, especially on an exam, but I wanted to hammer home this point, that if you see a VSD with bidirectional shunt, that is not equivalent to Eisenmenger syndrome. And this goes back to that, what we talked about in my lecture, that PA pressures are not equal to RV pressures, so you only assume that if there's no outflow tract obstruction. So always look for RV outflow tract obstruction as the cause of your RV hypertension. This was a very unusual case of that, but it's a great example of how to not confuse those two. If you're examining a patient who has Eisenmenger VSD, they don't have a murmur, because the blood flow is now very low velocity across the VSD. So this lady had a 3/6 murmur in the STEM question on exam, and so that was the murmur through her band. So if you hear a patient with a loud murmur, that's not Eisenmenger VSD. And then remember to review cath reports carefully. This lady actually had been cathed when she got put on the heart-lung list, and the band was noted, but the person who was in control of her transplant program was a pulmonologist, and I think he didn't understand the significance of the band. So, all right, thanks for your attention. Why was the banding done is the question. So nowadays we would just take a baby with a big VSD that we thought significant and close it directly. But I would say, 30, 40 years ago, we really didn't like to close VSDs in very small children. We wanted to get them bigger. They were a safer operation, easier to do the heart-lung machine, but we wanted to protect the pulmonary bed from the pressure overload of the VSD until we could put them on the heart-lung machine. So you do a PA band through a left thoracotomy, it's off pump, and you're just causing outflow obstruction to protect the pulmonary bed until you can bring the patient back to close the VSD.
How much time do we have left? Do we have time for a couple more quick cases? Okay, let me just go over a couple more quick ones. These are both entities that have appeared on the exam in the past. Okay, so one disease entity that has appeared on the exam in the past is that of anomalous left coronary artery arising from the pulmonary artery. This is also known as L kappa. This is a very rare anomaly, and in the kind of the classic presentation is an infant at about 2 or 3 months of age that will present with a severe dilated cardiomyopathy and symptoms of congestive heart failure. This is just a CT angiogram showing that the left coronary artery is arising off of the pulmonary trunk. It has classic ECG features, and often the diagnosis can be made just based on that. But what it requires is collateral blood flow from the right coronary artery to supply the left ventricle. And typically this is, at the time of diagnosis, will be repaired by reimplanting the anomalous left coronary artery back onto the aortic root. So echocardiographic clues to the presence of L-kappa include generally severe left ventricular dysfunction. There can be mitral valve insufficiency due to LV dilation or dysfunction, as well as papillary muscle infarction. You can see endocardial fibroelastosis of the left ventricle and papillary muscles. A failure to identify the normal proximal origin of the left coronary artery from the aorta. And then what you'll see is retrograde flow from the anomalous left coronary into the pulmonary artery. So these are all the clues by echo to this diagnosis. So this is kind of the classic infantile presentation of L-kappa. So these babies will present with a severely dilated left ventricle with severe dysfunction. With color flow imaging, we can see that this patient has started to develop some mitral valve insufficiency. Here's our parasternal short axis view showing the severely dilated and severely dysfunctional left ventricle with preservation of the right ventricular function. So here's our RV outflow view. So this is our pulmonary valve, main pulmonary artery. And so here we can actually see the origin of the proximal left coronary artery from the pulmonary trunk. Here's a kind of a high parasternal short axis view again showing this left coronary artery arising from the main pulmonary artery. And with addition of color flow, we see that the blood flow in this left coronary is retrograde with that color jet coming into the main pulmonary artery. So this would be repaired by just reimplanting that anomalous left coronary back onto the aorta. And remarkably, these patients can have complete normalization of their left ventricular function. So the patient that I showed here is now actually a junior Olympic caliber swimmer, so has gone on to have complete recovery of her LV function. And then finally, one other defect that has appeared on the exam in the past is that of total anomalous pulmonary venous return. So Dr. Phillips had already showed us some examples of partial anomalous pulmonary venous return. So in this case, there's no incorporation of any of the pulmonary veins into the left atrium. And what will be maintained is some connection to some systemic venous structure. So this has been called the supracardiac form. In this case, the pulmonary veins all come to a confluence, draining to a left vertical vein, to the innominate vein, and then ultimately back to the right atrium. There can be an infracardiac form, so these veins come together and drain down below the diaphragm and ultimately into the inferior vena cava. There can be cardiac forms, so sometimes there can be a direct connection of the pulmonary veins into the right atrium, or there can be a coronary sinus type of TAPVR where all the pulmonary veins drain into the coronary sinus and then ultimately back to the right atrium. In all of these, there's an obligatory atrial septal defect. So there's an obligatory right to left shunt at the atrial level, and that's the only way for blood to get into the left ventricle. So echocardiographic clues to the presence of total anomalous pulmonary venous return include enlargement of the right heart, usually quite marked enlargement. You'll see right to left shunting at the atrial level. You can see unusual membranes in the left atrium, and often what you're seeing is that confluence of the pulmonary veins back behind the left atrium, and it just gives it an unusual appearance. Looking for abnormal flow into the various systemic venous structures, so either the innominate vein, SVC, down below the diaphragm in the liver, you'll just see some unusual flow, which is the anomalous pulmonary venous pathway. It's possible to have obstruction of the pulmonary venous return. This is most common in the infracardiac forms, so that the pathway can be obstructed either as it passes through the diaphragm or as it enters into the liver. But without obstruction, these patients can be remarkably asymptomatic. So there's rare cases where people don't get diagnosed until they're in their teens or into adulthood. So this is an example of a patient with supracardiac total anomalous pulmonary venous return. So one of the striking things here, here's our left atrium, which looks just slightly small, but we see an extra structure behind it. And so this is actually the confluence that all the pulmonary veins are connected to with no connection into the left atrium. So here's our subcostal four-chamber view. So here's our left atrium. This is actually our pulmonary venous confluence sitting back behind the left atrium. And again, there's no continuity of the pulmonary veins with the left atrium. With color flow, we see the flow into the pulmonary vein confluence. And so this blue flow going away from us is the drainage into that vertical vein. And here we see very exuberant flow coming into the superior vena cava. And this is the right to left shunt at the atrial level. So here's our suprasternal notch view. So here we start to see some of the individual pulmonary veins, but the striking thing is this very prominent flow into this vertical vein, to this dilated innominate vein, and to the superior vena cava. And here's just a sweep showing the complete pulmonary vein pathway. So here we see all of the individual pulmonary veins coming together to form a confluence with drainage now to this left vertical vein, to the innominate, to SVC. And I wish you luck on your exam.
Try to answer a couple of the questions that came up. I think we have time for a couple of questions that have come up.
So a couple questions I had on coarc. One was how to manage that aneurysmal dilatation at the site of previous coarc. That's surgical management. We don't really do covered stent exclusion just because of usually it's near the great vessel takeoff. I guess in select cases you might be able to do that, but for the most part it's surgical. Do you recommend screening for intracranial aneurysms? The answer is yes. At least one time in your life, if you have a coarc, you should have your intracranial vessels imaged because of the association of aneurysm.
What if it's a bicuspid valve?
The question was raised, what if they just have a bicuspid valve? There is some data that you have increased risk of intracranial aneurysms with that, but at the present time, there's not a clinical recommendation for screening. That may come about as more data is gathered, but right now, I'm clinically not scanning just my bicuspid valve patients.
Okay, so a few questions here. So for test purposes, you would have to be given either a view of pulmonic stenosis or the pulmonary artery arising from aorta to distinguish between tetralogy of Fallot and truncus, right? And that's correct. So if you look at a peristernal long axis view, there's a number of entities where you can just see the aorta or truncal valve, and you see this overriding, semilunar valve. That view could be tetralogy, it could be truncus, it could be a double outlet, but you would need other views then to confirm that there's no second semilunar valve or that it's there and stenotic in the case of tetralogy. So, again, just showing a single semilunar valve overriding the ventricular septum is not adequate to make a specific diagnosis. You need to look at it from multiple different views.
So while you're reading that one, question about concern in LTGA from an electrophysiology standpoint. AV block and higher grades of AV block are the most worrisome finding. There is some accessory pathway issue, but usually we're most concerned about AV block and the need for pacing in those patients. You got your question ready?
You induced anxiety, exclamation point.
Yeah.
What is most common together? PFO, ASD, VSD, bicuspid aortic valve. So this gets into, we were talking about this before, kind of the, distinguishing an ASD versus a PFO. So a PFO is very common. 20% of adults will have one. Some of that is a bit of an arbitrary distinction, and what I typically look at is if it looks like an insignificant, tiny little defect, I'll call that a PFO. If there's a more substantial defect, then I would call that an ASD. So, PFO is definitely, the most common, defect.
And technically, too, not a defect, right? I mean, it's an embryologic
yeah,
structure.
Exactly. It's a remnant of...
So don't get too hung up. I mean, the most common defect is a VSD. The most common defect that we'd recognize not, for the first time in adulthood would be an ASD because we picked up the VSDs early. So I think we're all on the same page, right?
Bicuspid aortic valve is about 2% of the population. VSD would be, it's the most common congenital heart defect, and that would be 25% of all congenital heart disease, which is about 0.7% of the population. So VSD is 25% of 0.7%, if that makes sense.